Without further ado, I would like to introduce the speaker for today's session, Dr. Tan Ming Yeong. Dr. Tan is a registered nurse and credentialed diabetes educator from Australia. She is currently attached to the International Medical University Kuala Lumpur and Oriental Melaka Straits Medical Center. With a strong passion in diabetes education, Dr. Tan is the one of the pioneer diabetes educator in the country with more than 34 years of experience in diabetes education. Her main contribution to diabetes education in Malaysia is initiating and organizing regular National Diabetes Education Conference for local and Southeast Asia diabetes educator and also healthcare professional with the aim to raise the standard of diabetes education in the country and globally. Hence, I will hand over to Dr. Tan. Over to you.
Thank you for the introduction, the kind introduction, and the invitation. And thank you to all participants on such a sunny, bright Sunday to come and attend this talk. My talk this morning is on self-monitoring of blood glucose, current status and influential factors. This is my disclosure. The overview of my presentation. I will start with evidence of self-monitoring of blood glucose, particularly concentrate on non-insulin patients. And then I will explain on structure SMBG, illustrated with case study discussion. Then we'll look at the SMBG accuracy. Is it an issue? And lastly, how about HbA1c versus SMBG? Now, since many years ago, the evidence of SMBG for insulin user is always level B, as you are all quite well aware of the different levels of evidence. But for the non-insulin user, until today, as you can see, this reference is from ADA Standard of Care 2021. The evidence until today, it is still at evidence level E. One of the reasons is because as an insulin user, you can titrate your insulin dosage. Then when you look at the blood sugar, example, before you go for exercise, if your blood sugar is at 5, you're supposed to take a snack. But for non-insulin user, there is some limitation over there. One of them is, now, if you are going to go for a condoning now, you know you are going to eat more. You can't be doubling your dose. So the self-monitoring of blood glucose is mainly to guide dietary behavior, physical activity, the SU that can cause hypoglycemia. This is a meta-analysis presented by Pharma in BMJ in 2012. And even before that, the evidence for non-insulin user is always only 0.26, 0.13 reduction of HbA1c by SMBG. So the conclusion is always insufficient evidence for meaningful clinical effect. Then as you move on, this paper, another meta-analysis by Zhu et al., again published in BMJ Open Journal in 2016. Now you can see, it has included 15 RCT, 3,000 plus type 2 diabetes non-insulin user. The HbA1c reduction has gone up, a reduction of minus 0.33%, both for short-term and long-term user. This is another meta-analysis and is published in 2018 at the Diabetes Research and Clinical Practice by Macri et al. To look at the effect of SMPG on clinical outcome. He has included 5,000 plus patients. Now, at 12 weeks and 24 weeks, consistent reduction of 0.32%, 0.34%. But for this meta-analysis, it found that at 12 months, there is no difference. So the conclusion is SMPG appears to have short-term benefits in glycemic improvement. I believe that most of you are familiar with our latest CBG guideline for type 2 diabetes 2020 that was just launched recently. And in the CBG is stated for type 2 diabetes non-insulin user. Earlier evidence suggests lack of benefit with SMPG, but recent evidence suggests they could modestly reduce HbA1c by 0.12 to 0.33%, like the two meta-analyses that I showed you earlier, especially those who have short-term diabetes duration, those whose HbA1c glycemic control is very high, those who are obese, structural SMPC, which I will explain to you later what it is, more frequent SMPG, regular feedback with treatment adjustment, higher health literacy, and evaluation of technique. Regular evaluation of technique of the user is very important because that is one of the main factors for inaccurate SMPG. After saying all this, why am I so passionate in showing to you SMPG for non-insulin user there is a hope? Because globally, majority of the people with diabetes are type 2 diabetes. Out of the type 2 diabetes population, majority are non-insulin user. So what is structure monitoring? I call it evolution of SMPG practices. Many years ago, just like when I started practice as a diabetes educator, we mainly just concentrate on teaching the patient how to do the blood sugar testing. Then we may tell the patient how often to do and what time to do. And the story stops there. There is hardly any teaching the patient in interpretation and intervention of the result that include problem solving. So I have turned the triangle upside down now. For SMPG to be effective, you have to look at facilitating in interpretation and intervention that include problem solving. Unless all of us practice that, our clinical outcome for non-insulin user will remain the same. This is a paper by William Polosky and Lawrence Fisher on SMPG recommendation. It explains very nicely what is structure monitoring. So Polosky and Fisher has come up with the principle of structure, SMPG. 4 principles, in fact there are more, but I'm just putting up the 4. The first one, there must be sufficient data. If your patient is just doing once a week, once a month, don't do. It's not going to help. Second, SMPG data need to be recorded in a manner that address the specific clinical problems. This is where your recommendation come in. Now, are you helping your patient to look at, is it a medication problem? Is it a dietary problem? What are the causes of hypoglycemia? Number 3, the SMBG has to be meaningful to the patient. Don't do it to please us. Then there is no, it cannot sustain the practice of SMBG. And 4th, both the people with diabetes and us as clinicians, we need to be knowledgeable on interpretation and intervention of SMBG. I'm showing you 2 records from my patient. A on the left-hand side and B on the right-hand side. For A, well, the numbers are all over the place. Is it a medication problem? I don't know. Because on the fasting, there is a 7.3, not too bad. Is it a diet problem? I don't know. Because there is a 15.1, there is a 10.2. Whereas if you look at B, this is what we call structure monitoring. I know this patient have medication problem. Look at the fasting. It's all above the target of 7. Prandial, all above. Is it a diet problem? I don't think so that much, because post-prandial, there's not much different with before meal. There might be some for lunch. That is what I meant by structure monitoring, so that you can identify the problem. So the International Diabetes Federation 2009 actually published a SMBG guide for non-insulin user, and it comes out with 2 recommendations, broad recommendations. The first one, A, B, and C, is what we call high intensity. That means patients prick themselves very often. The first one, as you can see, before breakfast, after breakfast, before lunch, after lunch, and so on until dinner. And the second one is, you look at breakfast, then the next heaviest meal. And this B is very nice if the patient is on biphasic insulin, Novomix 30, Mixtard, and so on. Because you can see if the pre-dinner is high, is it because of post-lunch problem, or is it of insulin insufficiency problem? Or you can what we call stagger SMBG. You just do the meal, pre-meal, post-meal, for lunch, for breakfast, for dinner. So for high intensity, if you look at it closely again, it's between 14 tests to 21 tests a week. But a lot of patients don't want to test. So you can go for what we call low intensity monitoring. There's only 6 tests a week. You can look at the fasting on D, then you can look at the heaviest meal first. Or you can do every alternate day, 1 meal. 1 day for breakfast, 1 day for lunch, 1 day for dinner. Or you can do before sleep, bedtime, followed by fasting the next day. For this F regimen, very important, there must be, tonight if you want to do the pre-bed, you must do the fasting tomorrow, so that you can see the relationship between before sleep and fasting. If you do before sleep tonight and then 3 days later you do the fasting, then it does not serve the purpose. I'm going to now illustrate how do you use SMBG on a few cell care. First case is using SMBG to empower insulin therapy initiation. Madam S, 83 years old. She is not very big for 83. She had type 2 diabetes, hypertension, dyslipidemia, CKD 3A. Well, for 83, you do expect that. All blood tests are normal. There is urine protein. But she is a very good 83. She is functionally independent, no cognitive impairment. The medication include glycoside 160 mg/OM, metformin 1 gram BD, and linaclotide. The HbA1c is 8.9. If you look at her SMBG, all her fasting are above the target of 7, even though she is 83, because she is functionally independent. All her after food is almost the same as a fasting. So for using the IDF guideline for care of older people, there. So we discussed, my diabetes team discussed with the family, discussed with the granny, and she finally agreed to start a basal insulin. So we just put her on Tujo 10, sorry, it's 10 units, it's a typo error here. And because we put her on insulin, we have to decrease the glycoside. Look at it, 6 months later. The HbA1c came down to 7.4. And look at all her fasting. So it's come out what we call already single digit. And her post-meal are all within target. And indeed, we still have to reduce her glycoside 40 mg from 160 because we started her on Tujo injection. Again, I apologize for the typo error here. The second case that I'm sharing with you is using SMBG to identify causes for elevated HbA1c. Mr. N, 62 years old businessman, again, type 2 diabetes, hypertension, dyslipidemia. He's big, 106 kilo, BMI 35, BP is okay. HbA1c is 8.5, other lab tests are normal, no proteinuria. And he is already on 4 oral medication. Dimicron, empagliflozin, Genumet, 50 and 1 gram BD. After 3 months, same, HbA1c is still 8.4. And if you look at his SMBG, well, he doesn't want to do a lot, but there is sufficient to give me the information. He's fasting 7.2 to 8.8, sometimes down to 6.5. Is before bed, not too bad. For a 62, most time is below 10. So you have to interpret the SMBG reading with HbA1c. What HbA1c has shown you, if his HbA1c is between 8 to 9, you should be seeing more double digits. But I don't see it here. There must be somewhere there is a problem. So I discussed with him, let's change his self-monitoring blood glucose regimen to meal-related, that means the one before meal and after meal. See, now we found the problem, his breakfast. Fasting can be 5.3, after breakfast is 13.7. Fasting 6.3, after breakfast is 11.2. There is more than 3. 8 months later, we talked to him about his food intake, the quantity of his food intake. His HbA1c dropped to 7.8. It's not ideal yet, but it has decreased from 8.5. And because he decreased his food intake, naturally the weight comes down. And we maintain the same medication for him. Well, one day he will have to start insulin for him too. What do I mean by this meal-related SMBG? To assess the effect, is it a diet problem? You take the after food minus the before food, the difference should be less than 3. Look at that. After food, 16.8 minus 7.1 is 9.7. After food, 16.4 minus 10.1 is 6.1. Now, when the before food is very high, a lot of patients will just eat very little. They do have this self-care inner strength there in them. And when you want to do mealtime monitoring, very important, monitor right before starting the meal. Monitor 2 hours after finished eating. And this one, you can't do it for a Chinese 8-course dinner. It has to be a normal meal. And then record the result plus food intake for the meal. If it is more than 3, I always tell my patient, if it is more than 3, it is not I who say that you have taken too much of carbohydrate. It is your body that tells you so. And they have to take action. What action? Smaller portion. Substitute lower carbohydrate choices. Choose lower glycemic food items. Or you add in post-meal activities. Like one of my patients who is an engineer, when his blood sugar is 14 after food, he will go for 1 hour walk. And he tell me, you will be down to 11. Check medication adherence, medication adjustment. And this is the third case, using SMBG to empower lifestyle change. This is Missy, very young, 35 years old school teacher, type 2 diabetes. Actually, she was told she had high sugar in 2017. And she was told that she can go on diet control. But in 2019, when she first came to our hospital, the HbA1c was 8.6. She came here not for diabetes, but she had some weakness of the left hand, was referred to us tertiary hospital for further investigation. She's overweight, BP okay, and then other tests not significant. We started her on metformin XR, 750. So from the very beginning, I show it to her how to use SMBG to change her lifestyle, as you can see. From a record, before food, after food. And then she recorded all her intake. And she also started exercise. I just saw her about 2 weeks ago. Her HbA1c remains now at 6, less than 6.5. Her weight didn't come down a lot, but HbA1c did come down. And we have to reduce her. My doctor have to reduce the metformin XR to 500 mg. And this is the last case which I'm showing you how to use SMBG to adjust dietary issue. Mr. Y, 71 years old, type 2 diabetes, 12 years, hypertension, dyslipidemia, he is everything. He had CABG 6 years ago, heart failure, severe neuropathy, BMI 27, BP okay, blood test normal, and no proteinuria. Now, on the first visit, he was, for his heart failure, he was being managed by another teaching institution. He was prescribed with Atrapid 16 unit TDS. If you look at the left-hand side here, and Gragin 30 unit. That is, he's on basal bolus insulin with total insulin of 78 unit plus Genumet 50 and 1 gram BD. Look at his SMBG. These are all pre-meal. They are all in double digit, and he is on basal bolus dose. So my endocrinologist, our team, my endocrinologist, changing to Rizodex 32 in the morning and 20 in the evening. Maintain his Atrapid so that he can still use back this Atrapid, 14 units. So the total dose is 66 units. Maintain the Genumet, but we add in Jardians for him. on the third visit, there is a reduction of HbA1c 8.3 to 8.9, medicine same. And then you look at his SMBG, has some improvement, still not very good. My endocrinologist wants to start increase his insulin, his Rhizodec and atropine. So we discuss, I say, hold on, can we do something in lifestyle? I talked to Mr. Y, very interestingly. Now, I asked him, what is 10.3 and 9.9? He said, oh, less than 10. Can eat. He doesn't understand this is pre-meal blood sugar. So after food, definitely you go very high, 9.9. Before lunch, 14.6. So I discussed with him, discussed with the daughter that always come with him. Why don't we shift his monitoring time to after meal? Because to him, he only understand less than 10 can eat. So after we have changed his, so I told him, why don't we do it after food? And now I give you more until 12. No need 10, you can have until 12. And look at it. He's fasting. This is fasting. Sorry, this is the way he wrote it down. It's all back to almost normal. And on the 5th visit, his HbA1c came down to 7.6 without a change of medication. It's only a change of dietary intake, the quantity. Why do I say until 12? He is what I call it partially functionally dependent. He walks rather slow and he has a lot of comorbidity. So if his HbA1c is about 7 to 8, I'm happy. His post-meal, why it says 12? Because maximum is 12. And there, we have to assess our patient's literacy and numeracy. Below 10 means can eat. So all that I did is change his monitoring time. He loved to monitor. Change his monitoring time to after meal. Occasionally, he still get more than 12, but that is okay. Majority are less than 12. So we have already discussed structure monitoring. You have seen. This is another meta-analysis that assess the effect of structure versus non-structure SMBG on glucose control in patients with non-insulin treated patient. And you can see that HbA1c reduction of 0.27%, which is significant. Okay, now we come to the second part of the talk. Is SMBG accuracy important? Now, I understand a number of you are doctors. All that the patient show you is their written report. If we don't understand what are the factors that is going to affect the SMBG accuracy, we may adjust the medication not correctly. The main issue related to monitoring accuracy broadly can be divided into user and meter. User is the user technique that was mentioned in the CBG type 2. User condition. Meter is test strip and meters. I will go through one by one with you. User technique. Most important principle is clean hand and dry hand. Doesn't matter how you want to clean, whether you wash it with soap and water, you clean it with alcohol soap. It has to be clean and dry. Proper lensing technique with adequate blood sample. Don't squeeze. If the blood doesn't come out easily, please prick again. Avoid vigorous milking of finger because it's going to affect the result. And storage of the test strip, very important. Don't compromise storage. That means leave it under the hot sun, leave it under a very hot place. Don't use expired or damaged test strip. A lot of old folks, they do that, expired test strip. Or those who don't do it frequently. Then when you ask them to bring their test strip to you, it is already expired. Temperature and humidity do count. User condition. Hematocrit of the patient. If it is too high, in polycythemia cases, if it is too low, in anemia cases, it does affect the accuracy. The hydration of the patient, the attitude. Attitude are mainly, it affects those younger patients who go mountain climbing and those who stay in highland and things. Interference substance on the test strip. If they use glucose oxidate test strip, if they take a mega dose of vitamin C, you know, some of the patients, they take multiple supplements. Every supplement has vitamin C. I've seen patients who take 10 different types of supplements a day. Very high uric acid, dopamine, or mannitol, it can affect the reading. If the patient is a CAPD patient, continuous ambulatory peritoneal dialysis patient, then if they use this group of test strip, it can affect the reading. And those oxygen saturation, if the patient is in shock. And to go back to storage test strip, try to ask your patient to show you their blood glucose meter. If they say, wait, it's in my car, then you know their storage is compromised. So if we have factors affecting our accuracy of SMPG result, it can give you false high, like contaminated finger. If the patient have taken an apple, a fruit, the fruit juice, if they don't wash their hand, the fruit juice that's left on their finger will give you a higher number. Dehydration, anemia. High uric acid, just now that I mentioned, it has to be very high, more than 1,000 millimole or 20 milligram. Low oxygen level for those who are severe COAD, those who are hypoxia and high altitude. For false low, if they squeeze and squeeze and squeeze their blood sample, then you're going to give a false low. In the finger is wet. That's why I said the main principle is clean and dry. Polycythemia, high bilirubin has to be very high. High triglyceride is more than 15. High oxygen level. False high and low, well, expired test strip. Test strip stored in extreme temperature. Test strip container not compromised because a lot of the test strip are still come in container. They don't close it properly. Or alternate site testing during glucose variability timing. So the next one we come is meter. Just now I mentioned for all test strips, there are basically two big groups. One is called glucose oxidate test strip. That means it reacts to the oxygen. It can give you false low when there is high oxygen tension. As example, patient in ICU on high oxygen. Or false low when you're on high altitude, when you're hypoxia. Another group is called glucose dehydrogenase test strip, which is not reacting to any glucose, which is non-oxygen sensitive. So it doesn't matter about oxygen level of the patient. This one is only those patients on CAPD because the icodextrin that is added to the fluid of CAPD that helps with ultrafiltration of the fluid. It reacts to the body. The body does absorb about 20–30%, and this isotaxin reacts to the glucose dehydrogenase test strip. but it's quite safe. Majority of the test strip now in the market are glucose dehydrogenase test strip. Meters. We have ISO 15197-2003, ISO 19157-2030. ISO stands for International Organization for Standardization of Meter. This is a European guideline for standardization. Just like in the hospital, you have MSQS, you have JCI, and all these. You have to make sure it meets certain standards. If you look at this paper from Fragment et al., it shows you that earlier was ISO 2003. The blood sugar test, if it is less than 4.1 millimole concentration, it should be within plus minus 15 mg of the gold standard. If it is more than 7.5, it has to be within 20 mg. As we move on in life, they are more stringent with the accuracy of the meter. And this one, ISO 2013, we use less than 100 mg, and both of them must be within 95% of it must be within the 15%. Not only that, 99% of the result have to be within the CEG zone A and B, which I will explain to you shortly. Now, the American Diabetes Association just published this year. For America, they don't use ISO 15197-2013 or 2003. They usually go with their FDA, Food and Drug Administration law. For home use, it's not as stringent, but for hospital use, they are very, very strict on it. As you can see, home use, you have 95% within 15% of all blood tests in the usable BG range. What do you mean by usable BG range? That means every meter will have the lowest range. Some are 3, some are 2.1, some are 2, and the highest range. Some are 30, some are 27. So 15% of all BG usable range. And 99% has to be within 20% of all BG usable range. But in the hospital, can you see 15, 20? In the hospital is 12%. If it is more than 75 milligrams, that is 4.1, or more than 75 milligrams, 98% has to be within that, because in the hospital, that is where you adjust the medication very often. So what is CEG? Just now I mentioned to you. This is how they test. They test with a gold standard. There is a venous blood sent to the laboratory that is properly calibrated from 2.8 millimole to 27.8 millimole. A zone, there is A. When they correlate, it has to be within the A zone. Then there is no effect on clinical action. B zone, then there is little or no effect on clinical outcome. If you are C, D, E, can you see a 1C here? Likely to affect the clinical outcome. Being a member of the Australian Diabetes Educator Association, I received their e-newsletter a lot of time. And lately, I have just received this news. It said that we have been notified today that Meter A recently became aware that hydroxyurea, an anti-neuroplastic drug used primarily in chemotherapy, falsely elevate glucose reading on Meter A system. This can result in a failure to treat hypoglycemia from misloads sensor glucose value. That means the actual glucose value is less than 4, which the patient is supposed to correct the hypoglycemia, but meter A is reading higher than 4, maybe 4, maybe 5. So that means the patient don't need to treat it. Then it has adverse clinical outcome. And lately, I found another meter. Actually, now the ISO standard has gone to 2050. So that is very more important. You have to be even more stringent with the meter accuracy. Now I come almost to the last part of my talk. You monitor your client's HbA1c regularly. Yeah, a lot of GP do that, because when I go give talk to a GP in workshop, a lot of them do monitor your patient's HbA1c. That is excellent. Do you still encourage them to perform SMBG in their daily life? So that is my question to you. Just want to share with you this case of mine. 63 years old Mr. Y had bypassed 5 years ago, renal function normal. That is the medication he's on, Genumac 50, 1 gram BD, dimicron MR 60 mg/m, and Tujo 18 unit in the night. And this gentleman, very good. He's doing his SMBG 6 points a day, twice a week. You see his number, all beautiful. But over the last 2 years, every time he comes for follow-up, his HbA1c is 8% to 9%. If I put side by side, I'm using this guide that you can get this from the Type 2 Diabetes 6th edition that was just released. This table, you can get it from there. If somebody having a HbA1c of 8 to 9%, you should see quite a lot of double digits. But you look at his SMBG record, they are all single digit. So when we explain to his family, we say we need further investigation. He finally agreed to do a continuous glucose monitoring. Now, if you look at his continuous glucose monitoring for a week, he has hypoglycemia at night and early morning. And he is not young. That is not good. My endocrinologist actually has to reduce his 2U to 14 units, and his CGM also calculate HbA1c. His HbA1c based on this continuous glucose monitoring is 5.2%. I'm going backwards to show you again. This one. If his HbA1c is 5, between 5 to 6, that is his SMBG. It correlate, right? What my message for you is, when you see, it's not very common, we do have a few cases, when you see somebody persistently having a high HbA1c and yet the blood sugar home monitoring is normal, then you might want to ask them to do a CGM. Or if you think that their home monitoring of SMBG reading does not correlate with HbA1c, then you need to investigate further. Can we have 4 factors that affect HbA1c value? Yes. And this is adapted from the CBG Type 2 Diabetes 2020, where they adapted from Campbell also. You can have a false higher HbA1c value when you have a deficiency of anything that increase the turnover of electrocyte turnover. So you can see iron deficiency, B12 deficiency, folate deficiency. And you can have a low HbA1c value. Again, a lot of them are related to anemia or blood transfusion. So if the patient just have blood transfusion, don't check the HbA1c, it's not reliable. Again, treatment with iron, treatment with B12, treatment with folate. All these can give you either a false high or false low. If either higher or lower, then a lot of time is due to their hemoglobin problem. Hemoglobinopathy problem. Or ethnicity. Indian and Malays are supposed to be higher, but well, Mr. Y is a Chinese, and some medication, that's all. But once you have treated the anemia is stable, then the HbA1c result, you can trust it. So the take-home message is SMPG improve clinical outcomes of insulin user. There is increasing evidence it improves non-insulin user too. Structure, blood glucose monitoring combined with timely intervention improve clinical outcomes and quality of life for people with diabetes. Accuracy of SMPG, operator technique, meter and test rate are important to guide us in our patient management. Both HbA1c and SMPG are important, and each of them has their own rules to assess the glycemic status of the people for the people with diabetes. And I adapted this from IDF SMPG for type 2 diabetes in 2009. Now, SMPG is only a tool. It is not a drug. It has to be used by people with diabetes. It has to be used by healthcare team. We have to educate our patient, and hopefully SMPG help them to change their behavior. For the healthcare team, we optimize the therapy for people with diabetes. And the impact is great. Improve metabolic and clinical outcome, improve safety of use, quality of life, and long-term financial, because patient will get less chronic complication. In 2015, Canadian diabetes educator said that SMPG is self-management of blood glucose. With that, I end my talk. Thank you for listening.
Thank you, Dr. Tan, for the insightful sharing. There are a few questions from the floor. May I read out? I will read out to you.
Thank you.
Yeah. Can you explain how continuous glucose monitor system can help in blood glucose control?
Thank you for the question. Very practical. Lately, we do have continuous glucose monitoring. They are basically two types. The one that I show you is what we call professional continuous glucose monitoring. You use it to identify problem. The other one is by the patient. Now, because of continuous glucose monitoring, we are actually monitor the to identify problem. The other one is by the patient. Now, because of continuous glucose monitoring, we are actually monitor the times a day. So you can draw the line 1 week. And then you compare, look at the result. Where are the trend? Where are the hypo? Where are the hyper? That it helps us to manage our patient. And because it is a continuous glucose monitoring, you sit down and explain to your patient. At the same time, the patient will need to record their food intake so that they know what are the food intake that causes a high sugar, what are the food intake that helps to control their blood sugar, and what happened to their blood sugar when they exercise. This is especially helpful for those with type 1 diabetes. I hope I have answered your question.
Thank you, doctor. The second question is related to a dialysis patient. Are flash glucose monitor in guiding insulin dose in peritoneal dialysis patient?
Can I have the question, flash insulin? You mean the Libra insulin, blood Libra meter?
Yes, are flash glucose monitor useful in guiding insulin dose in a dialysis patient?
Okay, the Libra flash dialysis meter, yes, I will have to have more information from the company. Is it affected by the isodextrin or not? So I cannot actually answer the question directly now, because if you are using the glucose test rate, the one with glucose dehydrogenase, it does affect with the isodextrin, but it is still useful to adjustment, except I need more information on that. I'm sorry, I cannot give you the answer now, but I have to check out with Abbott Diabetes Care.
Okay, thank you. This question is, how about a pre-diabetic patient? Can the person control without medication?
Thank you for the question. Very interesting. We have lots of pre-diabetes. Depending on the level of pre-diabetes, the blood sugar is still helpful if they check, is it impaired fasting or is it impaired glucose tolerance? That means post-meal. If it is an impaired glucose tolerance, yes, you can do a pre and post-meal, then you check your blood sugar. If it is more than 3, then it helps. And that will also help you to reduce your body weight. Just like a lot of pre-diabetes are overweight, that helps. If it is an impaired fasting, then it's a little bit more complicated, because then, of course, high fasting, there are a lot of reasons. One of them is your meals can be too much at dinner, or pre-bed before you sleep, you still take supper, or in the middle of the night, you still eat, or sometimes it is, they won't go into Somogyi effect or Somogyi effect, but there can be a problem of down effect. So if they can identify, they continue with their healthy lifestyle. If they can bring down their weight, yes, why not go without medication? But that will depend on their doctor's decision too.
Okay. The next question is, may I know what does it mean by vigorous milking of finger? Is it okay to squeeze the finger prior pricking so that to ensure there is enough blood for the testing?
Again, thank you for the very practical question. I agree with you. We should milk the finger, squeeze the finger before you prick, not after you have pricked your finger. When you see there is a very little drop of blood, when you try to squeeze, you are actually squeezing body fluid and finger. That will affect the result. Thank you very much for your question, very practical.
Okay. This question is, if patient complain due to the they doesn't have much money to buy the test strip, what is the appropriate option of lesser SMBG monitoring timing can we suggest?
Thank you very much. Again, very relevant question, very practical question. there are a few factors that you have to look at. The first thing you want to know, what are you looking for? Are you looking at medication problem? If your patient's blood sugar is very high, HbA1c is very high, you want to look, is it a medication problem? Then I like the the F regimen. That is before you sleep and tomorrow morning. Then if you are not eating, theoretically your blood sugar should drop. If it doesn't, then you have to look at why. Because the one you only do once a day, if a patient don't want to do a lot. Once you have sorted that out, if it is not a medication problem, then the patient can always do a less monitoring by looking at meal time. So it depends on whether the patient want to do 6 times a day, 6 times a week, or 4 times a week. Before meal, after meal, but choose different timing. After a month, each meal, breakfast, lunch, and dinner, you should have 3 readings to assess it. You cannot have 1 reading, that will not be accurate. So that I find that is very helpful. We look at, is it a medication problem or is it a dietary problem? For those who don't want to monitor very often, but it will take a longer time to identify the problem. Thank you.
Thank you. Due to time constraint, we will take the last question. This is related to the fasting month. How to manage high blood glucose during fasting? Which regimen is recommended to identify the cause and how to manage?
Is a question related to Ramadan coming?
Yes, yes.
Okay, for Ramadan, there is a Ramadan guideline. High fasting, usually we will have to assess the patient before Ramadan. High fasting is the question directly throughout the day high, or is it when sahur high or buka puasa high or when? So those are the questions that I will ask. If it is throughout the whole day is high, there is usually a medication. If it is when they early in the morning or in the day when there is very high, it can be due to their food intake. So one of the very good points at assessing is it a medication problem is when they buka puasa. What is the blood sugar reading? If it is high, that means throughout the day is, I mean, if you puasa from dawn to from morning until you buka puasa in the evening, then if it is persistently high, then you may have to adjust medication. If after fasting for 12 hours, your sugar is back to normal, then very likely it is a dietary problem. Then you have to talk to your patient about diet, especially when they buka puasa, they take a lot of high sugar dense food, drinks, they eat a lot, then they will result in a lot of high at night and early in the morning. And if they take the in the morning before they start fasting, if they take a lot of food, that will cause a lot of high too. So during fasting, in fact, the timing of monitoring is 7 points. So a lot of patients don't want to do. So I usually tell them minimum, you have to make sure you do at noon and mid-afternoon to make sure you're not going low, not high, but not going low. Because if they are low, hypo, they have to break fast. Really, there's a very good guideline. They have revised the guideline already. Hopefully, I answered the question.
Yes. Thank you, Dr. Tan. Once again, thank you very much, Dr. Tan, for the sharing. And thank you, audience, with all your input on the question as well. We hope you gain a lot of insight from this session. Our next session is warding off vaginal infection, which will start at 11 a.m. Do stay tuned if you are interested. Meanwhile, while waiting for the next session to start, you can pay a visit to our exhibition hall. Have a great day ahead and goodbye.